نقول بسم الله الرحمن الرحيم. I hope you had a good lunch and awake enough to consume what's going to be given here today. On our last session, it's really a rich one, lots of speakers here. But before all, I'd like to remind you about the Fema Health 2023, which will be held next month, inshallah, 17-18 فبراير in Le Méridien Hotel في جدة. It's a major conference. We have oncology, gynecology, endometriosis, fibroids, lots of minimal invasive surgery, if you like. We have experts coming from France, Finland, and India. 3 major minimal invasive surgeons coming. And also we have a breast session, which is really related to the OB-GYN. And finally, we have a sexology and psychology session on Saturday. Plus the pre-congress workshop, which is on hysteroscopy and colposcopy. All right, so now we're going to start our last session, and it's my honor, really, to introduce our chairpersons here, Dr. Fadwa Tahir. She's an assistant professor at Al-Qura University in Mecca. She is also a consultant obstetrician gynecologist. She is a maternal fetal medicine subspecialist, and she's working also here in يسموها طريق الملك إتوال مظبوط إتوال clinics. Anyway, really it's Dr. Fadwa. She's been actually working hard when she started her career in Jeddah with me, and I used to take out Dr. Intisar Madani all over the kingdom teaching ultrasound. So the 3 of us, the 3 musketeers, went to Qasim, Tabuk, Al-Ahsa, teaching ultrasound. She is one of the really hard workers, actually, who joined me in these remote courses. And also I'd like to introduce my colleague, former resident of mine, is Maher Khalifa, did his training in King Khalid National Guard Hospital in Haras. Now he is the CEO of Hira Hospital in Mecca, mashallah, and he's leading the committees there for the 2030 transformation of medical care in Mecca al-Mukarramah. Actually, without any further ado, I'd like to hand over the floor to the both chairpersons. تفضلوا.
طيب السلام عليكم ورحمة الله. We'll introduce Dr. Nadia Al-Hazmi, who is a consultant maternal fetal medicine in East Jeddah Hospitals, ex-medical director, and also she is a member of the Scientific Council of the Saudi Commission of Health and Specialties, and currently she is the RTB. The presentation today with Dr. Nadia Al-Hazmi is about 2 lakh. Enjoy your time. The mic for you, Dr. Nadia.
Thank you very much for your introduction. Welcome back. I hope that you are still awake and there is place of another session which is really fatty. So I'm going to talk about the delivery after cesarean section, and my main goal is to have more people who are believing in giving a chance and to be expert while we are doing the counseling for those patients. These are my main objective of this presentation, just to identify the risk and benefit of VPAC and ARCS, identify factors which favor or reduce the likelihood of VPAC, outline the consideration of counseling, the mode of delivery, and induction of labor augmentation, and we are going to have some discussion and argument regarding this point especially. Then we'll see the recommendation of care of women who are having the VPAC. All right, we know that the cesarean section rate have been dramatically increased all over the world. And we know that the overrate cesarean section in the MOH hospital reached 35.8%, and the percentage is escalating as well. The increase of primary cesarean section rate had led to increase the proportion of women with history of cesarean section. So I'm reinforcing the first statement have been mentioned by the prof that we need to work to reduce the primary cesarean section. Then the option of subsequent birth, the planned VPAC, which is a result either in vaginal delivery or an emergency cesarean section. And then we will talk about the elective repeated cesarean section. The primary indication for cesarean section in Canada is previous cesarean section, according to the statistic. Over 30% of the OR list is a previous cesarean section, and I believe in the Arab board is the percentage is almost the same. I'm talking about the governmental hospital, and I think the statistic is even worse in the private sector, because many of the hospitals adopt not to give the ladies these chances, and only 10% they are having the chance when they come in advanced labor, rather than electively counsel them regarding delivery and with previous cesarean section. So that's why all the international society have revised themselves, revised their guideline, and then produce guideline how to increase the VPAC and how to encourage more obstetrician patient to be to have this option and to be courageous enough to give the right patient the chance of having vaginal delivery after cesarean section. If we go for our local statistic, and I had great difficulty to get the statistic because it's just institute, rather than having the general statistic for all the hospital. We have the most common indication was previous cesarean section as well, with almost 31%, so we are not far from the international figure, and these were in university hospital and another governmental hospital. These are few definitions, and I believe everybody knows the VPAC and TOLAC and ARCS, but the two definitions where it's not very clear for especially our junior resident when we write our notes is the difference between the uterine scar rupture and uterine scar dehiscence. The difference between them, as you can see in the screen, that the complete separation of myometrium with without expulsion of fetal parts into the maternal peritoneal cavity is called rupture. And the dehiscent when the fetal membrane are not ruptured and the fetus is not outside the uterus, usually the peritoneum over the defect is intact, and usually those dehiscents are not accompanied by maternal or fetal mortality and morbidity. And I believe many cases we go to the OR electively, especially for repeated cesarean section, and we find that those are dehiscent. So we need just to mention it, because when we counsel her regarding the next delivery, when to deliver, what's the right time, is completely different between rupture and dehiscent. So it's really crucial to write it very clear. And if I don't know whether it's rupture or dehiscent, I will just describe it as I see it. Okay, so we come now for the factor increase the likelihood of successful TOLAC. As we all know that previous successful VPAC is one of the indicators that most probably this one will be successful as well. Previous vaginal birth, favorable cervix, spontaneous labor, non-recurrent indication like breech presentation, and maternal age less than 40. These are the factors which will reduce the likelihood of TOLAC, which is previous cesarean section before for dystocia. So once you calculate the chance of having another vaginal delivery will be less than the usual percentage. Need for induction of labor that required cervical ripening. Need for augmentation of labor if the gestational age is more than 40 weeks, and if the baby is larger than 4 kg, although I think most of us will be hesitant to give her a chance of vaginal delivery, and the maternal body mass index, which is more than 30 kilometers per meter square, and hypertension as well. All right, so if the website there have been proposed by the fetal-maternal group, and if you click it, you will have all the details for the patient. Her age, her body mass index, whatever the indication of previous cesarean section, gestational age, the fetal weight, then they are automatically calculating the chance of that lady to have successful TOLAC. So you can tell her that particular for specific patient, your chance of having vaginal delivery is 70%, your chances of having successful vaginal delivery is 45%. So I'm encouraging everybody to take a picture of it or go to the website and you will have it, and it will be a really great tool to counsel your ladies. All right, so when we come to the benefit of having VPAC, we have maternal and fetal benefit. And if we are electing our ladies very well, considering all the previous things we have mentioned, the overall success rate is reached to 75%. And I believe there is 2 studies have been published from the Western region where they had the same success rate. And there is another study have been done in the middle region. They have success rate of 70%. And again, they were really electing those ladies who have the potential of having high successful rate. So just remember the green dots and the gray dots. So there is a higher chance of those ladies who have been elected and counseled according to all the factors which we have mentioned, that they are going to have successful TOLAC. All right, so if she had vaginal delivery, we know that the hospital stay is less, and she has a faster recovery, and we know that she will avoid the recurrent cesarean section of having 2 cesarean section. We know that her chance of having morbidly adherent placenta is less and less, and the satisfaction of having vaginal delivery, she achieved it and she did her goal. So basically all the risk regarding anesthesia or repeated cesarean section will be less, and the breastfeeding will be higher. Again, remember all these blue dots and 1 red dot. So just remember this picture and have it in your mind, that only that small dot, which is 1 in every 200, they might have the complication and they may have ruptured uterus. So there is a higher chance of having successful vaginal delivery. All right. So we know that the risk, apart from having the rupture, if she had the vaginal delivery, there is potential of trauma of perineum and pelvic floor and increased risk of sphincter injury for women having second birth following 1 previous cesarean section compared to non-Paris. So we need to counsel them regarding that. We need to practice whatever Dr. Sabah mentioned early morning, so to reduce the chances of having all the OSs. The benefit of baby, it's well known that the breastfeeding at the beginning, bonding, command, it will be more whenever she has vaginal delivery. The fetal risk of having VPAC, and usually the ladies, they will elect to have repeated cesarean section for these bold 3 lines, that there is increased risk of perinatal mortality compared with the elective repeated cesarean section. There is a chance of 0.1% risk of stillbirth if we waited while to reach the labor, than an increased risk of HIE, God forbidden, if she has ruptured uterus. And if she has ruptured uterus, there is a risk of hysterectomy. And people arguing that if she has repeated cesarean section, the risk will be still there, and there is increased risk of hemorrhage and transfusion as well. Okay, so if we want to have safe January, we should know whom to elect and whom to be excluded completely from our selection of patients. So the first one is previous uterine rupture, as we have mentioned in the previous definition, and because there is high risk, 5% greater of recurrent rupture. And previous classical cesarean section, the risk of rupture reached 3 to 5%. And the other contraindication, like major placenta previa, and this is by common sense. All right, so our obstetrician nightmare that this lady, she might have ruptured, the signs and symptoms is not really clear, it might be missed, and it might be, and I agree, but this will just help us to think about the major presentation which have been listed in this slide. We might have abnormal CTG, and sometimes we don't. And we might have abnormal bleeding, and it's really misleading. More than 50% of ladies, we run to the OR with minor bleeding, and we found them with intact scars. Abdominal pain, especially if persisting between contraction, cessation of previous efficient uterine contraction, acute onset of scar tenderness, abnormal progress of labor, hematuria, loss of intrauterine pressure, chest pain or shoulder pain, and this is a very late sign where she starts to have intra-abdominal bleeding, and easier palpation of fetal part, or sometimes is cessation of the presentation part. It's -1, then seeded to be -3. All these are signs and symptoms of rupture uterus. I know that we will have discussion regarding previous two. Not with, I confess that I'm not with giving chance of a lady with previous two cesarean section to have vaginal delivery. I have many ladies who have been transferred to my care asking for having vaginal delivery after previous two. Usually because the risk is high, we don't give them that right. I don't have the courage yet to give them that right, but in the literature, there is no absolute contraindication of giving those ladies a chance of having vaginal delivery after previous two cesarean section, and there is accumulation of number where ladies, they have successful vaginal delivery after previous two. This is one of the very important slide that whenever we are electing our ladies, we should ask them when she had the previous cesarean section, and the best duration is 18 months, where you can think that the integrity of the cesarean section is well, and she can have a chance of having another VBAC. So this is really important, that how we are going to counsel our ladies in our antenatal care setting. We need to discuss the risk and benefit, and we should give them the figure without having pious counseling. What we are seeing in the clinic, that whoever in the clinic, if he's bro with the VBAC, he will have directive counseling regarding having a VBAC. You will be fine. But we have everybody around you. Less likely that you are going to have cesarean section. I have so many ladies that deliver vaginally, and we don't tell them the real risk, and usually it's على كيفك يا دكتورة, which shouldn't be the case. And in the other side of the coin, you are going to have rupture uterus. You are going to have HIE. You're going to have, your baby is going to have, and we might end with hysterectomy. So this directive way of doing the counseling, it should be abandoned. We give the patient the right figure, the right counseling, without being directive. All right, so we have our ladies, and we took the history. Just follow me with this flow chart. So we have our ladies, we took the history, and we took all the previous things which we have mentioned. We did unbiased counseling or undirective, so she knows her chances of having successful vaginal delivery. She knows her risk, and she's electing to go with you with the journey, which is really good. You go and thoroughly look for the favorite likelihood of vaginal delivery, so you tell her this is the right percentage for you to have the vaginal delivery. Mind you that we don't know exactly what will happen through the labor. This is your chance. We might succeed in 75% or 70% or 60% according to her actual risk. And we are going to do certain follow-up during the labor. If she's contraindicated, so from the beginning that we will recommend for her that she should have elective repeated cesarean section. So the surgeon plan should be done at 36 weeks. Usually the ladies, when you counsel them early in the pregnancy, they are with vaginal delivery. They want to have vaginal delivery. Then afterwards, while the pregnancy progresses, they have change of mind. So you need to repeat that at 36 weeks. Okay, so you have a lady where you have a planned vaginal birth after cesarean section. So she's either have spontaneous labor or she doesn't have spontaneous labor. If she has spontaneous labor, we will just need review the medical record, review that she has informed consent and signed, and regarding the insertion of the catheter with or without, usually most of the institutes, they don't put the catheters. Then we need to do all the precaution for having this lady going for cesarean section. We need to have full preparation that at any time we might take her for cesarean section, from blood count, from CBC, and having cervical screen. If in the other side that, sorry, oopsie, okay, how can I go back? Guys, hello? نقدر نرجع؟ okay, yes, I found it. Good. So we have in the other arm that she did not go on spontaneous labor. So you need again to sit with her and discuss that whether she need induction of labor, and the incidence of rupture will be increased. It will almost triple if we are going to do the induction. Most of the institute, they are going with a catheter rather than using prostaglandin or oxytocin. So we need again to sit with her and tell her that what her chances of having rupture with induction of labor. Mind you, even with mechanical dilatation with balloon, the chances of rupture will be increased. Then we'll have, if we go there, both are having satisfactory progress, and if yes, well and good, and we reach our aim. But the life is not that easy. We'll go for ladies who do not have satisfactory progress. So if I'm into VPAC, I should complete the journey till the end. I will tell her, if you didn't have good progress, I'm going to augment you with oxytocin. If I'm going to augment you with oxytocin, the risk will be higher. With each step, we need to tell her the whole journey and what we are going to do. So here, of course, if we are going to start oxytocin, it should be at a higher level, at a consultant level, rather than any other level, because the patient should know her risk exactly. And if she has satisfactory progress, well and good. If not, we'll go for emergency delivery. And here I'm just putting again the signs and symptoms of uterine rupture. Whenever we have a lady who having VPAC, it should be one-to-one care, and she should be in an area where you monitor her vital signs all through. There is dozens of consent which have been published in the different society, and here in Saudi Arabia, I believe عندنا هنا اسمه الاستشارة المستنيرة للولادة الطبيعية بعد القيصرية. It's 14 pages, and I'm encouraging everybody to review it. You don't need to have the 14 pages. Every hospital will tailor it according to their needs. I think you need only one and a half page to tell the lady what's her risk, what benefit, and what the complication might arise. And usually informed consent is really important to be there and to make sure that it's in her documents all through, because we know that they might have change of heart. At the beginning, she will tell you, I'm with you, even if I have rupture, we'll go to the journey, I want to deliver vaginally, but whenever any complication arises, litigation come. So if my documentation is complete and the consent have been written clearly and she signed it, even if there is litigation, we are in a solid ground. This is my last slide, and if you were sleepy, like the guy at the end, just concentrate on this slide. It will just summarize the whole thing. The VPAC is a reasonable and safe choice for the majority of women with previous cesarean. The increased risk of uterine rupture associated with TOLAC underlie the need of careful selection of candidate, counseling, and management of labor. Induction may be attempted by oxytocin, should be used in caution. In patients who have protracted active phase of labor, the incidence of uterine rupture is low. It is a serious complication for both women and the infant. The essential to discuss the risk of TOLAC and the repeated elective repeated cesarean section, including the effect of mode of delivery, will be in subsequent pregnancy with women who have a previous cesarean section. Thank you very much for listening.
Thank you so much, Dr. Nadia, for your excellent presentation. I really enjoy your presentation. We'll leave the questions to the end of the whole presentation, to the end of the session. And please welcome with me Dr. Rima Badros, who is the consultant maternal fetal medicine in IMC, and she is the chairman of the MFM unit in International Medical Center in Jeddah. Her presentation today will be about when to deliver twin vaginally and how. Please enjoy the presentation. You are more welcome.
So just a brief, to go over the type of twins. We have dichorionic diamniotic twins when the cleavage starts between 1 to 3 days, monodi from 4 to 8, mono more than 8 days, and conjoined twins when the cleavage anything more than 13 days. So the incidence of twin, in generally, it's increasing, and even in Canada, in the last SOGC guideline, it's increasing, and we know that it's because of the ART and the pregnancy at advanced maternal age. So in general, it was a bit of dilemma when to start or from where to start my talk. So I decided, as far we are just going to talk about the delivery and management in delivery room, it's wise to know the timing of delivery of twins. So less than 50% of twin pregnancy reach gestational age of 37. In general, uncomplicated dichorionic diamniotic twin pregnancy, the aim of your gestation to planned delivery is between 38 plus 6. This according to the ECOG and SMFM. SOGC lastly said that it's between 37 to 38 weeks. Uncomplicated monodi between 36 to 36 plus 6. Mono between 32 and 34 weeks to prevent the complication mainly of entanglement of the cord. Safety of twin vaginal delivery for uncomplicated dichorionic diamniotic twin pregnancy when the presenting twin is cephalic. After 32 weeks, the mortality will be the same in cesarean and in vaginal delivery, and it won't increase in the mother or the fetus. And it's the same by the twin birth study, which was published in 2016. They said that after 32 weeks, the risk of cesarean section or the planned cesarean section will not improve the outcome of the fetus or the mother. So in general, or the most important thing, planned vaginal delivery should be supported when the care provider skilled in managing second twins is available. Twins who are not for a trial of vaginal delivery, when there is no expert staff, obstetric contraindication like placenta previa, previous scar, non-cephalic first twin because of the unique complication of locked twins, gestational age below 28 weeks, or estimated fetal weight below 1.5 kg. So in general, I will start from the type of the twins that you can see in delivery room. We have the 3 types of twins or the presentation when they are cephalic. They count for 42% of the whole twins. Cephalic, non-cephalic, 38%. Non-cephalic, 20%. 7% of them non-cephalic, cephalic. 13% non-cephalic. So from those twins, the twins that can go for vaginal delivery is mainly the 80% of the twins, which are cephalic or cephalic non-cephalic twins. So if the patient had no any contraindication to go for vaginal delivery, if the twins are fulfill the criteria to go for a vaginal delivery, mainly the uncomplicated dichorionic diamniotic twins, the patient after 32 weeks and below 39 weeks, the first one is presenting by head. So now I need you just to concentrate because the lecture will be divided into delivery of the twins, cephalic, non-cephalic, and cephalic-cephalic. We'll start with the delivery of the first one, and then we will move to the delivery of the second one, if he's cephalic or if he's non-cephalic. So we'll start. You planned for a patient to go for a vaginal delivery and she's twin. Number 1 and number 2 and number 3 is the availability of obstetric staff that capable to do maneuvers, which is breech extraction, internal or external version of the second one, or to go for emergency cesarean section. Anesthesia should be available and ready in the delivery room. Pediatrician or pediatric staff should be ready to receive 2 infants. So the patient in delivery room, you have to ensure that she is having adequate intravenous access, type and screen, blood ready for her, no intake restriction should be done to the mother, and when she's active labor, fluid diet will be fine. Ultrasound machine is a must to be in the delivery room. Fetal monitor is the must to be continuous for both twins. It's either you will have a machine that ready to monitor 2 twins, and you have the strip of the CTG for the 2 twins, at least 10 beats per minute to say that this is twin A or twin B, or 1 internal and 1 external. And if you don't have a machine with 2 monitor, use 2 machines, but you have to synchronize them with the time and the timing of the paper and the contractions of the mother. Cervical ripening with an oxytocin, it's like a singleton. You can use the prostaglandin, catheter, and oxytocin like singleton. Analgesia and anesthesia, it's the best to provide good pain relief with epidural because the patient can go for emergency cesarean section and you can apply instrumental delivery versus the maneuvers. So the patient now in delivery room, the progress was perfect, as equal as singleton, because the studies never mention who's faster. There was varies in the study, but the patient now is fully dilated. So when the patient is fully dilated, you need to move the patient from regular delivery room to the OR. And why we are doing this? Because you might need to do immediate cesarean section, so the setting will be much more appropriate. You need anesthesia in the OR. You need 2 incubators, and you need extra hands and expert obstetrician. And the OR for sure has a better lighting. So the procedures, if you are planning to deliver the first one, it will be as equal as singleton. So you will do your episiotomy as needed. You will do forceps, vacuum according to your situation. Cord clamping, in a case of dichorionic diamniotic twins and you are sure of your diagnosis, you can delay the cord clamping for 30 to 60 minutes, but if you are not sure, better not to do it because you might compromise the second twin. Labeling, be sure that the label of the twins are equal in the cord attached to the mother and the cord attached to the baby, and twin A, and during your scan, it shouldn't be twin A after delivery, because after delivery, twin A will be, or twin 1 will be the one delivered first. So after delivery of the first one in the OR, everyone in the OR should take a breath because now we will start the journey of delivering of a second twin. So number 1, delivery of the second twin start with assessment. So you need to assess the mother, if the mother is doing well, if she is vitally stable, how is her contractions, and then you need to assess the baby. The assessment of the baby will start by ultrasound, fetal heart rate monitor, and vaginal examination. The fetal heart rate will give you a breath that everything is okay, fetal heart is okay. Vaginal examination and ultrasound will determine the position of the second twin, if the baby is encephalic presentation or the baby turned and he's not. So 12% of the second twin were found to be in a non-cephalic presentation after birth of the first one. Among cephalic non-cephalic twins, 30% of the second twin who were non-cephalic on admission were cephalic at delivery. And the interval between the delivery of the two twins, it's never determined as far as the CTG and the fetal heart is normal. If the second twin in cephalic presentation and the CTG is okay and the progress of labor is fine, you can start oxytocin whenever the contraction is spaced, do rupture membrane with head engagement. If the head is not yet engaged, you can do still controlled rupture of membrane by using a spinal needle and let a second twin deliver as the first one. But if the second twin is cephalic, but the head is high, and you are thinking that the cervix might close, so the delivery of the second twin will be difficult, at that point, you need to do the maneuvers to expedite the delivery of the second baby. So if the patient is consented and the patient agreed, we can start with what we call internal budalic version or breech extraction, i.e., you will go in, let's say that you are examining the patient is fully dilated, you will go in and the ultrasound, you are doing the ultrasound to check if it's head, where is the feet of the baby, try to grasp the feet and hold the head from up so the baby will not move, and then push everything down. And we have to do this just in case not only the cervix might close, the complication might happen because the head is high, so the patient might have cord prolapse, hand prolapse, or abruptio placenta that require immediate delivery. So this is again the procedure. The first one will come. The second one, with the aid of ultrasound, you will go in and try to grasp the feet with intact membrane as much as you can, and then hold the head up so you can support yourself, and then you can deliver the baby with a breech extraction. So last time I did this, it was in 2015, yeah. So it's the same, and it's the same in here. And this is again the procedure. The only thing that you might need to give nitroglycerine to the patient just to relax the uterus more. And we can do, if the patient did not agree, or you counsel the patient before going into this journey, and she told you, no, I'm not agreed to go with breech extraction. So the other thing that we can do, which is external cephalic version. So it should be like when the membrane is still intact, you will do as external cephalic version as we know and bring the head down. But we have to do this quickly before the cervix is closed, and it has some still difficulties, and it's not as straightforward as the breech extraction, at least. So if we will go with this, it's a very short diagram, but if the patient agreed to go for vaginal delivery and the baby is like cephalic, monitor the fetal heart, perform rupture of membrane, augment with oxytocin, fetal heart is okay, wait for spontaneous vaginal delivery. Non-reassuring fetal heart rate, perform operative vaginal or cesarean delivery. If the patient had non-cephalic for the second twin, so you need to, does the patient consent for breech extraction? If yes, do it immediately. If no, if she is counseled for external cephalic version, do it and proceed as step 1. If not, perform immediate cesarean section. So delivery of the second twin in unplanned cesarean birth, if unplanned cesarean for a delivery of a second twin is not uncommon, occurring in approximately 4 to 10% of all planned vaginal delivery, but it's associated with increased mortality and morbidity on the mother and on the fetus, but sometimes you had to do it, mainly in case of abnormal fetal heart tracing, abruption, or failure, or prolapse. So in a case of cephalic, non-cephalic presentation, we offer most of the patients with cephalic, non-cephalic twin a trial of labor with attempt of breech extraction, but again, if the patient refuses, it should be a planned cesarean section from the beginning. So if the patient with cephalic, non-cephalic twin opt a trial of labor, we would not perform breech extraction in the following setting. So just keep those in mind. Number 1, when the estimated fetal weight of the second twin is bigger, because the first twin, the head will be down, the head will get molded and it will deliver. But the second twin, the head will be big and it will not have time to mold, so the delivery will be difficult and you might have entrapment of the fetal head. Number two, prolonged second stage of labor, or estimated fetal weight and the molding of the head. That's it. Yeah. Management of the third stage of labor, it will be as management of third stage of labor in general delivery, but you have to be sure that you are managing well the possibility of atonic uterus or postpartum hemorrhage, which is higher in twin pregnancy. And you need to examine the placenta and to send the placenta for histopathology if required. And examination of the placenta is to determine the zygosity, mainly in the twins who are of the same sex. And that's it. Thank you very much. And those are my brother and sister twins, both vaginal delivery. They are almost now 35-ish. First was cephalic and the second was delivered by breech extraction. Yeah.
Thank you very much, Dr. Rima. Now, I'm going to introduce Dr. Sabah Al-Larkiya. She is a consultant of obstetric and gynecology, and she is a section head of obstetric and gynecology in King Abdulaziz Medical City in Ministry of National Guard. She will give us a small talk about an introduction of advanced life support of obstetric, which is known as ALSO.
Assalamu alaikum. Hope you're still enjoying the day. As usually after lunch we feel sleepy and want to bed, especially it's Jum'ah. So advanced life support is one of the courses that we do advise the interns, residents, and even seniors to attend. And just to give you a hint, what is advanced life support? It's a structured evidence-based multidisciplinary training program that deal with obstetric emergency and neonatal resuscitations. So the beginning was in 1991, where the American family physician has originated this course. And then in 2001 also was adopted by other obstetric training programs in different parts of the world. So over 50 courses has been held in Australia and New Zealand, and more than 2,000 maternity care professionals were trained. In 2007, Kingdom of Saudi Arabia was licensed to have these courses, and initially we were helped by instructors from Sudan and UK to conduct the course for 3 courses. And then in 2008, we were start doing our own training with their guidance, and in 2010 we became an advisory faculty. This is the visit of the American Academy of Family Physicians in 2015, where we were visited by them and accredited to have these courses as solo. This courses is being conducted all over This course is being conducted in all over the kingdom. We went to Al Jawf, Al Madinah Al Munawwara, Mecca, and the original regions in Riyadh, Dammam. Also now they are running the course in Yumba. Also the team has visited Bahrain in 2009-2010 to conduct this course. So the course is made of 3 days. In the 3 days, we start with the updated lectures and hands-on stations. So we have updated review of safety in maternity care, maternal resuscitation, preterm labor, fetal monitoring, and medical complications. And we get hands-on stations on different stations where we use manicans and special mnemonics to help us to learn and memorize and to remember the steps especially during emergency. It also has helped many people to write their documentations because their ideas now is already arranged. So the hands-on station include neonatal maternal resuscitation, postpartum hemorrhage, shoulder dystocia, malpresentation, and operative deliveries. So this is our postgrad unit in National Guard Hospital where we conduct our course, and this is the latest program for also in 2023. We have already started the January course. Inshallah, in February we will have the course 15 to 16, and we will have a total of 5 courses this year, inshallah. If you would like to register in the course, there is the link for the course for registration. Part of the also course is a basic life support, which is one-day course, and it is specialized for the midwives and nurses. We give almost the same lectures, and they have a chance to have a hands-on station and some of the special emergencies that midwives need to learn about. They might conduct the delivery by themselves, or they will learn how to help the physicians when they encounter such an emergency. An example of that is postpartum hemorrhage, shoulder dystocia, how to interpret the CTG, and when to call for help. Thank you very much. So I hope that we'll have more registrations in these courses where you're going to learn how to arrange your thoughts, inshallah.
Thank you, Dr. Sabah. As you end your presentation about the BLSO, which is intended for the midwifery, so now I'm glad to present Ms. Raghda Dahlan, who has a master's degree in midwifery.
السلام عليكم مساء الخير جميعا. I hope everyone will enjoy my lecture about the next topic. Okay, let's spice up the topic. Just please, I kindly ask you to scan the barcode. Scan the barcode, please. It will ask you to put 2 words regarding to alarming CTG. When I said now alarming CTG, what is the first thing pop in your head? Just write 2 words about it. Fetal distress, contraction, sinusoidal, life-saving, deceleration, Cat 2, Cat 3. So now we will try to cover these topics regarding this alarming CTG. If we want to summarize all what's written here, we will summarize it to 3 main topics: Cat 2, Cat 3, and the contractions or tachysystole. So let's start our presentation, please. So back to the presentations, we will present and talk about the CTG. Presentation, please. So first, let's have a different view for the CTG. The CTG machine have a different role and different aspects in the environment and birth and delivery room. The CTG can be the babysitter because it is babysitter. It is midwife partner, and it will be your backup protector in case of medico-legal cases, and is disturber in the normal delivery. And it is requested guest. So this is the way how to see the CTG in different role in delivery room. I just want briefly to remind ourselves about the 3 categories system, Cat 1, 2, 3. We will see Cat 1, it's mean the normal CTG, normal figure of the CTG. The heart rate variability is moderate or present. The late and variable deceleration absent. The early deceleration could be seen. I will skip CAT2. For the CAT3, it's mainly combinations between two important things. Absent variability combined by any kind of deceleration plus brady or tachycardia and the sinusoidal pattern. This is also another tier for the classifications, depend in the color. They combine the three category system with the color system. So like you see, the CAT1, it's go for the red, while the CAT2 have the three colors, blue, yellow, orange. The management for the CAT1, you have to do nothing, just observe and allow for normal progress. Then we have the blue CAT2. We have to take conservative techniques. Yellow, you have to take care also to increase the surveillance and monitoring of the baby. Orange CAT2 to do the same and to try to expedite the delivery. CAT3, it's red and you have to deliver the baby. This will make our life easy, because the CTG, since it's introduced to our world in early 50s, 60s, now more than 55 years, and we still have the argument in labor and delivery about the CTG. It is CAT2 or CAT3. What we have to do, have to wait, we have to do the cesarean section. As a midwife, we see all the team argue, and sometimes we interfere with this argument with them. So 50 years of argument, and hopefully someday this argument about the CTG categorization will end. So this will ease the life a little bit. If we take this table show two variables. The upper variables is talk about the deceleration, while the other one about the variability in the baseline. And you just pick up the color and follow the classification. So the CTG interpretation was hampered with many factors. One of them, that it's intra-observer and inter-observer effects during the CTG interpretations. Since 2008, the American College, the Society of Maternal and Fetal Medicine, the national institutions have determined the main definitions and standardization of the CTG. And yet we still have the confusions and the argument. We have, like you see, the classifications is very clear. The standard and the definitions about the features of the CTG is very clear. Yet, it's difficult to be diagnosis. So why it's difficult? Because the pattern is changed. Because during the labor, the fetus will not maintain the same heart rate. This is something I hope everyone to have the courage during the delivery, especially new midwives or new residents. They have to accept these facts. The baby have little bit to have difficult time during the labor as the mother. This difficulty in diagnostic will lead to two main things. Over-orientation. The over-orientations mean you will do over-caring for your patients. Especially if you will take these patients immediately to the cesarean section, will lead to increasing the cesarean sections in the private and governmental sector. Then we have the failure to intervene. It is in the other hand, some people, they will not intervene at all. Some people will have over-interventions. So it's very important when you are dealing in the CTG and the interpretations to do something very important. You have to do customization or custom care plan for the patients, because if you take these informations and you apply it to your patients, you will over interfere or you will fail to intervene. So it's very important to customize this information for your patients, because we cannot apply all this categorization system in our patients. Interpartum category tracing management. We will start. What is this CAT? This is the CTG. Will CAT what? 3. Who says 3? Raise hand. 3, 2. So this is CAT 3 because as definitions and classification system, it's combined two things: the loose or reduced variability with variable deceleration. So this is classic variable 3. I will not go with the details, but I will give you the hint what is the dilemma or why is the argument about dealing with the CTG with CAT3. Dealing with the CAT3, it's very tricky because all the disagreements for the teams or intra-observer disagreements about the variability. So we see sometimes the senior said the variability, it's okay. The junior practitioners, they said no, the variability is good. So the disagreement about the variability make every CTG CAT3, we are handed it as a category 2 and take the patient to cesarean section. And this is the tricky part about the CAT3. So this is the reason why the management strategy for the CAT3 pattern lead to same whether variability is absent or minimal. So what is the overall management of tracing with CAT3? The overall management, we will do the general approach. We when talking about the general approach, I'm talking about fetal scalp stimulation, uterus resuscitations, take the considered of operational delivery or cesarean section according to the patient's progress. So if we have patients with CAT3 and we do stimulation and the baby not response, we have to wait for 10 minutes, and after that we have to deliver the baby, whether C-section or operative delivery. The sinusoidal pattern still have the same management. We have to deliver the patients generally, but even though we have to try to stimulate the baby and take the general approach. If the baby responds to us, that means we will go and to continue observe the patients. If the sinusoidal pattern continue to present, we have to deliver the patients. So this is about the CAT3, what is the easy CAT. About category 2, which have many pattern and confusing pattern, that's the CAT that we have more attention in our delivery room and the argument. So this is pattern, it's uncertain clinical significance because it have combinations between bad signs and good signs. So again, what is the general management in the CAT2? Perform also scalp stimulation because sometimes even the patient's CAT2, sometimes they will respond to the scalp stimulation, the CTG will improve. Assess the variability, then do the evaluating other factors and initiate or more resuscitative measures like uterine resuscitative measures and frequently reassess the patients. I will take the most common pattern that we can see it in the CTG. The first one is fetal tachycardia. Fetal tachycardia, it's not taken seriously as fetal bradycardia, but it's very serious conditions that sometimes it's been neglected by the obstetricians and healthcare provider because they're not taken seriously. But sometimes if the baby suffer enough from hypoxia, have prolonged hypoxia, you will not see bradycardia in your CTG, you will see tachycardia. So tachycardia can be ominous signs in your CTG unless there is obvious sign. There is many factors that can increase the heart rate of the fetus. One of them, the prematurity of the fetus. So we have to make sure the baby is mature and the baseline is convenient for his gestational age. And another reasons to have tachycardia is maternal infections. So we have to look out for the causes. If we are exclude all the causes of the tachycardia, we have to follow up very carefully in the fetal tachycardia. If we have fetal tachycardia, once we lose the variability, so the categorizations will change from CAT2 to CAT3. So when we have tachycardia combined by losing variability, we have to deliver these patients. The other pattern or other things in CTG or CAT2, it's late deceleration without loss of variability. So it's very important to know late decelerations is it will be worsen when it's combined by losing of variability. But in category 2, if you see late variability, late deceleration with maintaining the variability, the moderate variability is associated, 90% is associated with pH more than 7.1. And if we have late decelerations combined by acceleration, there is strongly associated with pH more than 7.2. Why I want to enforce in this information is because from my experience in labor and delivery room, I see many obstetricians take immediate actions when they are seeing late decelerations. We have to really to care about how we are reading the CTG and how to interpret the CTG in systemic approach, so we cannot just to intervene with the patients. This is a variable decelerations with maintaining the variability. So variable deceleration without losing of the variability. If we're having a variable decelerations and we are maintaining all the variability is there, we have to do something and comparing how many variable deceleration we have. If we're having a decelerations not combined, less than 50% combined by the contractions, this will be less likely to be contributed by acidemia or fetal hypoxia. But we have to be careful. If this variable deceleration is recurrent and it's cover more than 50% with the contractions, that time we have to take care about the frequency, the depth, and the shape of the variable deceleration. Then we have the loss of variability without deceleration, the opposite. Losing of variability and without deceleration, this is one of three. Either the baby is sleeping, or the mother take a medication, or it is hypoxia. So if it's fetal, I cannot just see a CTG with losing variability and go back and they said, okay, baby is sleeping. This is not correct management to do. It's very important if we have admitting CTG or the first CTG we're having to these patients, if the CTG is starting by reducing variability, we cannot assume this is a sleeping pattern. We have to make sure before assuming there is a sleeping pattern, there is at least 20 or 30 minutes of reactive CTG. After that, if the variability is being minimized, in that time we can say it is sleeping pattern. About the medication is very important also when we are looking to the CTG, ask if the patients previously take any medications or narcotic that can affect the variability. Regarding to the hypoxia, it's very difficult to be exactly or to know exactly if there is hypoxia or no, but we will see what is the other tool we can assist the baby with. The other button of the CAT2, it's a prolonged deceleration or bradycardia. If there is a bradycardia or prolonged deceleration, you have to be careful about this pattern because it can dramatically change to CAT3. So it's very important to take in your consideration the time frame when you have prolonged deceleration or bradycardia. So what is this? What you are seeing in this CTG? This CTG, it's either black or white, but if you are saying this is a CAT1 CTG, I will argue with you because you are seeing the acceleration, but I'm seeing deceleration. So this is a very tricky, and having unstable baseline is very confusing because it will change our mind, our treatment, our whole care plan for these patients, and even the mode of delivery. So it's very important when we're having unstable baseline to give the patient chance just to clarify what is our baseline. Because every accelerations you are seeing in the CTG can be a deceleration, and the opposite is correct. So the CTG can having acceleration or deceleration. So this figure, just to summarize what I have said about the management management of the CAT2. CAT2, it's mean moderate variability or accelerations. If there is variability and accelerations, we will take the first path here. If the variability is not moderate, that means it's reduced variability and no acceleration, you have to consider how many variable deceleration we have. If the variable decelerations more than 50% of the contractions, that means we will have to take the patient to C-sections. If no, we have to observe. If the pattern is still there, we have to take patients to C-sections. If no, we have to manage according to algorithm again. If there is moderate variability and there is acceleration, we have to see again the decelerations more or less 50% of the contraction. If it is more than 50% of the contraction, we have three things to look after. We will assess the patient. She is in latent phase, that means she will take time to deliver. So it's better to deliver her cesarean. If she is in active phase, we will see she having a normal progress or the patient she will deliver soon or not. The second phase, if the normal progress, we will allow for normal delivery. If it's not, we will take the patient to cesarean. And although there is the algorithm, although there is the guidelines, the categorization system, classification system, still we have struggling how we will manage the CTG properly. We will talk about the related topics to the CTG and alarming CTG, which is hypoxia. I will go through it as three classifications. We have like acute hypoxia. Acute hypoxia will occur with prolonged decelerations that's lasting for 5 minutes, or will happen with 3 minutes associated with reduced variability. We have to take care to put in our mind the pH of the baby will drop 0.01 every minute in the acute hypoxia. What our management will be, we will follow the 3 minutes rule. If we have acute hypoxia, in the first 3 minutes, we have to prepare ourselves and to prepare the patients to move her to emergency delivery. The next 3 minutes, from 3 to 6, we have to diagnose the cause. If the cause was accidental cause that we cannot correct, we have to take care about our management. About the third 3 minutes, we should note and reassess the CTG if the variability returned or not. By the 9 to 12 minutes, and that time we have to take our action and our decision to deliver the patients. If we have acute hypoxia, we have to deliver the patients according to 3 minutes rule within 12 to 15 minutes. Then we have subacute hypoxia. Subacute hypoxia, it's mainly associated with hyperstimulation uterus, and this will cause fetal pH will drop 0.01 also, but here 2 to 3 minutes. What we have to do, it's obvious because we know the cause here. It is related to hyperstimulation uterus. So in case if these patients have induced by oxytocins, we have to stop the syntesolone or the oxytocins and allow the patients and allow the fetus to return to normal fetal heart pattern. Then we have a gradually evolving hypoxia. This have even the hypoxia will be prolonged for the baby. The baby will have the fetus will have this sequence of stress. First, will be hypoxic stress, loss of accelerations, exaggerated response to hypoxic stress, attempted to redistribution of previous vital signs, and in this time the fetal heart rate will be rise and you might see tachycardia. Then further redistribution and terminal heart failure. So it's very important how you clinically judge the CTG, because judging the CTG is not easy as it seems. It's very important to avoid prolonged fetal hypoxia, but in the same time to avoid the over-intervention. So does intrapartum monitoring, fetal heart monitoring, improve the outcome? At 2017, a meta-analysis research was conducted to compare continuous CTG monitoring with intermittent. This was the finding. There is no statistically significant difference between intermittent and continuous CTG in the following: acidemia, Apgar score, neonatal in ICU admission, hypoxic ischemia, prenatal mortality, and cerebral palsy. So there was no difference between the two types of the monitoring, continuous or intermittent. Although use of continuous monitoring resulted in fewer neonatal seizures with no differences in long-term neurological outcome. Continuous electronic monitoring resulting more operative, more cesarean, fewer spontaneous vaginal, and that's why we don't want to just make this percentage to be increased. So please consider the CTG is a machine. CTG is not monitoring. CTG is recording. You are the one who will monitor. CTG only will record information, record in the paper, but it will not monitor the baby. You will be the monitoring. The CTG is recording. CTG have many issues. CTG is have false positive, high sensitivity, low specificity. So just consider the CTG is a machine and you are the person with having the whole picture. And please consider the fetus. Consider the fetus gestational age, consider the fetal age, consider the fetus conditions, consider if the fetus is more likely to be delivered normally or operatively. So it's very important just not only to focus in the CTG. Also consider the mother. Consider the mother, her conditions, if she have another illnesses, and look at the CTG, not only machine, this machine is connected with two persons, the mother and the fetus, and you are the person have to go to see the whole picture. And consider yourself. Consider yourself, that's mean, consider your possibility and your potential. Do not jump to operative vaginal delivery, especially forceps delivery, if you don't know how to do it very well. Because I have seen, I don't want to say, it's almost no one know how to conduct proper instrumental delivery regarding to the forceps. So using the forceps delivery, and you are not, I don't know all the obstetricians, but it seemed to be just, I don't know. In 10 years ago, the midwife in the MCH, المساعدية, we used to hide the forceps from the doctor. This is the truth. Why? Because we really, the outcome both for the fetus and for the mother was dramatic. And that's why I know yourself, know your capability. If you are not familiar with the CTG, just call your senior. Then know your team. Knowing your team in the CTG is very important. If you know your team, if you know your midwife, her experience, you can rely it in her or no. See if this setting of the one you are doing the monitoring of the fetus, having proper transferring the patients and proper timing from transferring the patients from delivery room to the operating room. See if this hospital providing any additional assessment or tool that can help you during interpretations and management of the CTG. So, what do you think? CTG, enemy or friend? سلاح ذو حدين. So CTG in my mind is frenemy. So it could be enemy and could be friend. So the most important message for all of us after this lecture about the CTG, do not rely on the CTG, do not depend on CTG, because it will not give you the right decision and will not give you the right management. Thank you.
Thank you very much for this interesting lecture. I'm very happy to see a midwife such amazing like you, and I hope you will be a leading for our midwife in our loved country. Now the next session, I cannot present where I'm sitting, for our senior consultant of obstetrics and gynecology, for our godfather in obstetrics and gynecology, Dr. Hisham Arab. I will not present anymore like this. His lecture about the art of labor induction.
Very good. So I choose the easiest topic to talk about, okay? Because the whole day we've been talking about induction of labor, doing normal deliveries and all that. So really, I mean, nothing much to talk about. Maybe I'll be stealing some of the advices from what you heard from previous presenters, just to put it here on this. Well, anyway, induction of labor, it's a common obstetric intervention that stimulates the onset of labor using artificial methods. And the rates of IOL, induction of labor, nearly doubled after the 1990, and 25% of the neonates born following induction of labor. And there is a rigorous research has been published to continue to be published for two purposes: maternal and fetal safety during induction of labor, and more specifically to reduce the cesarean section rate. And this is I've been saying since the morning, reduce the cesarean section rate. So let's do more IOLs, more induction of labor. This slide just to tell you exactly when you intervene, okay? Because you're inducing labor. A woman, يعني في أمان الله, she's pregnant, and suddenly you tell her, okay, I am to stimulate your labor here now. So there are some timing, which is really, I mean, has been indicated here nicely in this table. For example, you're talking about, in case of oligohydramnios, 36, 37 weeks. IUGR with no abnormal Doppler, up to 38 to 39 weeks. Plus, IUGR with absent end diastolic flow is about 34 weeks. And then IUGR with reversed end diastolic flow at 32 weeks. So it shows you where actually even not one single IUGR is the same. It depends on your assessment. So you have to do the Doppler, any case of IUGR. And it tells you here when to intervene according to your findings. Maybe 32 weeks, or if you think Doppler is normal, you go to 38 weeks, though it is an IUGR. And then, of course, chronic hypertension with no medication, 38 to 39 weeks, gestation hypertension, 37 weeks or later, PET without severe features. Now we're talking about the new definition of PET, you know, with the without or with the severe, which is the proteinuria and others, which is really the 37 weeks or later. PET with severe features, of course, what we call the 34 weeks or early induction for these ones. And then pre-gestational diabetes that is well controlled, you take her to 40 weeks, 39 plus 6 days, all right? And gestational diabetes on diet and exercise and well controlled, still you can take her up to 37 weeks or 40 weeks. And then you have the pre-labor rupture membrane, which is a PROM at 34 weeks, usually if you can wait. Otherwise, if you have chorioamnitis developed, whatever, then you have to intervene earlier, like cases of chorioamnitis and IFD. I didn't put any date there because it just depends. Whenever it occurs, you have to do it. Okay, so that's a start. Now, what do we use for induction of labor? Of course, I know this is medical student slide. You have the cervical ripening, use the balloons, oxytocin, prostaglandins, which is mainly the mechanical versus the pharmacological induction. And then, of course, we have what we call the cervical ripening, which is usually maintained, is done after, before the cervix reaches 6 bishops. Now, for cervical ripening, we have two methods, either the amniotomy, which is really something that really relies on the cervical dilatation. Okay, cervix is closed, you don't try to do amniotomy. So for this purpose, you have to consider, first of all, the fetal head, the station, and the engagement. You don't want to have cord prolapsing in your hand. At the same time, also patient's preference. You have to counsel patient well to do that. We heard from Dr. Nadia this morning, you don't need to do the amniotomy if she is really progressing very well and having a normal CTG. So, but sometimes you need to do it and look at the amniotic fluid. Is there a blood meconium stained or not? So there is an indication for it, but it's really sometimes we have to wait till you do it in the right time. Laminaria is something like osmotic dilators. I mean, I don't know if we have it here. I've seen it in Canada only. Just a small, pieces of wood that really absorb the fluid, so it really gets thickened or widened, and that's why it really causes the dilatation of the cervix. But of course, it's also not really very much popular. Regarding the mechanical dilatation, we always use the Foley catheter, exactly. But there is also the sophisticated double balloon. Foley catheter is enough. You have to insert it near the head there, outside the amniotic membrane, 30 to 80 ml. 60 ml is fine, okay? And then you should just attach it to the patient leg and let it go by time. It has been shown that the 80 cc is working better than the 60 cc, according to this study, giving a faster delivery. And of course, the pharmacological, and we have the misoprostol, the dinoprostone, and then the oxytocin. You're all familiar with this one. With the misoprostol, you can use the 25 up to 50 microgram, using it every 3 hours vaginally, and for 5 doses. Or the dinoprostone, either we use the 0.5 milligram gel, or you can use the insert of about 10 milligram that you just leave it there for some time. And oxytocin, every delivery unit has their own policy. So I work in many hospitals, especially in private now. So when it comes to induction, I ask the nurse, the midwife, what is your policy here? How many units you mix it with how much of fluid, and what is your rate? You'll be astonished. You find one hospital have a different maximum dose compared to the other one. I do respect that, okay? Because each unit they have their own policy, and you have to respect that one too. So, then you have the contraindication. You can see the vasoprevia. Of course, you don't want to do nick the artery and causing the bleeding. Transverse fetal presentation, umbilical cord prolapse, history of prior classical cesarean section, active herpes infection, and also a previous myomectomy or entering the uterine cavity. And for the complications, we have here what we call, for the mechanical, it's considered as a very safe, and that's why this is the ideal approach for TOLAC, okay? Which is really have a safe delivery because it is, mechanical. The stimulation is far less or almost rare, and also it has a low cost. However, the pharmacological still can be done. Sometimes is more appropriate, and of course you have to be wary of the hyperstimulation in the pharmacological induction. What are complications as a result of induction of labor? We have fetal distress, meconium stained, umbilical cord prolapse, pain not relieved by the epidural, sometimes it's so severe, perineal lacerations, chorioamnitis, intrapartum, postpartum hemorrhage, and this is some kind of, just in general, how the induction of labor can precipitate problems like this. So for this purpose, you have to enhance the teamwork. We just heard it from Radha. We have to talk about, your team and how we can really work together whenever you have an induction of labor. You have to communicate. You have to, between nurse, midwife, and or obstetrician, all right, about why we're inducing this patient. And sometimes really is important, we have induced this patient maybe for hypertension, but nobody has looked at her medicine charts that she is now needing her dose of whatever antihypertensive she's taking. But we actually concentrating on how much the cervix is dilated, what's the CTG looking like, and all that. So it's very important to have the full picture and not to miss things around this area. Clear communication and professional staffing, Continuous CTG is very important whenever you want to do, induction of labor, and should have policies and protocols. Again, this is something has to be really looked very nicely and tightly in each unit, and you should follow it and respect it. Then, of course, for the there are some studies here just to show you the comparison between different approaches or tools. There is a study here comparing the prostaglandin E1, which is the misoprostol, the cytotec, compared with the prostaglandin E2, which is the lanoprostone, and the randomized trial intravaginal misoprostol as compared to the misoprostol in this intercervical gel, and did not find much really. It's very comparable. Misoprostol versus the oxytocin, there was no difference, again, between the two. However, the time for induction to delivery was a bit shorter in the oxytocin group, according to the American Journal. Single to double balloon catheters, we've seen the balloons. Actually, again, they don't really differ much a bit from each other. The osmotic dilators, I'm talking about the laminaria, versus the synthetic compounds, which is Lamisil, which is similar to the laminaria, but it is synthetic rather than natural, also has some kind of work about the same. But always remember with these laminarias dilators, there is a risk of infection, or chorionitis. Now, this is just also to look at the criteria where we need to utilize the induction of labor to lower the cesarean section rate. To minimize the section rate here, the induction of labor of nulliparous woman with an unfavorable cervix has twofold increase in the cesarean section rate. So this is a fact that we have to live with, all right? But the trick is how to really approach this. So as long as we are aiming for a vaginal birth, okay, the obstetric care consensus on the safe prevention of primary cesarean delivery recommends before proceeding with cesarean delivery for a failed induction of labor, prior to reaching an active phase of labor, you have to make sure that this patient has gone through oxytocin given for 12 to 18 hours after membrane ruptured, and as long as the, of course, maternal and fetal condition are appropriate or are okay. The latent phase of labor may be as long as 24 hours. It happened to my daughter-in-law. She was kept actually 36 hours in a latent phase in UK. And I know there's a system that's quite different, but they think, well, she's fine, baby's fine, leave her alone. They don't want to interfere like here. Prolonged latent phase in itself, not an indication for a cesarean delivery. Oh, she's been in the labor room, and especially here. The moms and the aunts and the father and the grandmother comes in. She's been in your unit for a day now. Why don't you take her just for a cesarean? As long as it is in a latent phase, is not an indication for a cesarean delivery. The active phase was defined as 6 centimeters. We used to call it 3 to 4 centimeters. So after this new initiative of reducing the cesarean, they said, maybe let's make it 6 centimeters so we can have a longer latent phase, all right? So this is the concept. We're still running behind. Leave her alone. Leave her alone. Okay? She's okay, baby's fine. Don't just rush and do the cesarean section. Okay. And of course, the goal is here, the workshop summary on preventing the first cesarean delivery from different institutes. The INCH, the Society of MFM, the ACOG said failed induction of labor is defined as actually after 24 hours of oxytocin, not 18 hours. Even they said 24 hours oxytocin, and artificial rupture membrane is there. So it seems to be from all angles, just telling you, hold on, wait, all right? Don't rush to the cesarean delivery. Now, the mummy or 4-mummy trial, this is very, well-known trial. Well, they're comparing the combination of different tools or methods of induction. In this one, they had included 490 women randomized to 4 different groups. All of them are singleton, term, vertex, Bishop score of less than 6. All right? And they have group 1, they used Foley catheter, and misoprostol. Group 2, Foley catheter with syntocinon. Group 3, only misoprostol, and group 4, only Foley catheter. They found that those that the combination has faster median time to delivery compared with those using just one method of delivery, according to this curve. You can see there the time reached delivery. Here, for example, 35 hours, there about 50 hours. According to the color, you can see these differences. However, look at this. When adjusting for further variables, a Foley catheter with syntocinon was not better than single induction method. So it seems to be still with single method induction, you can reach or appreciate the importance of this, doing induction. Now, Dr. Rima will be upset now because I'm invading her topic now, which is twins. Twins really, throughout my whole life, I've been trying to convince doctor not to do cesarean section for the second twin. For God's sake, I hear that sometimes I'm sitting in the labor ward waiting for my patient to have a baby, and there is another doctor taking this patient. Oh, he's emergency cesarean for the second twin. I feel sorry because I never done it. As long as you really master the delivery, once you deliver the first one, you can do the external podalic, you can do internal, you can rupture membrane the right time. But why you rush for, even if it's transverse, why not? Just do a little bit of rotation. So it seems to be that, unfortunately, this is an art that maybe we have to teach our residents. I mean, you shouldn't do a cesarean section for the second twin. So for this purpose, I had also prepared some slides to show about the induction of labor for twins. Approximately 20% of twins had an elective induction of labor. Induction of twin pregnancy is associated with twofold increased risk of cesarean section compared to the spontaneous labor onset. Okay? And then in women where amniotomy was possible, induction of labor had no increased risk of cesarean delivery. So that's a very small, tricky thing. And that's why sometimes if she's fine, twins, and they are doing all right, and still the cervix is a little bit harsh, wait another week, okay? And then you can do the rupture membrane and amniotomy and the carry on. Induction of labor with Foley catheter or prostaglandins associated with a slight increase on cesarean section, and failed induction with the cesarean performed in the latency phase was a common indication for cesarean section, about 30%. So this is the induction rate, the cesarean section with the induction in twins. There's a famous study, the TBS, the Canadian one, which is the twin birth study. It's an international, multi-center randomized controlled trial that compared the planned vaginal delivery to planned cesarean section. Okay? So it seemed to be that they said, okay, we are a group of you guys want to do cutting, all right? So do your cut. And here we have, I got this group of patients. No, I want to wait on them till they have a normal delivery. And they compared these two groups. And look at the study reported there was no difference in fetal and neonatal outcome between the two branches. So if you plan your patient, just because she's twin and you take her for cesarean section, you're not doing her any much favor or additional favor, okay? In other words, cesarean section before labor did not reduce the risk of adverse neonatal or maternal outcome compared with planned vaginal delivery. IOL in twins is considered a reasonable and safe method. The likelihood of cesarean delivery did not differ between the two groups, 19% versus 21%, nor did the time from induction to vaginal delivery mean between 9 and 10 hours. And the results were not different when we looked at the nulliparous patients versus multiparous patients, though you can see some difference in other studies. On adjusted analysis, actually, of the risk factors of cesarean delivery in patients undergoing induction, twin pregnancy was not independently associated with cesarean delivery, and that's why Patients with twin pregnancies undergoing induction of labor have a similar risk of cesarean delivery and a similar length of labor as patients with singleton pregnancy undergoing induction of labor. So don't say just because she's twin, no, I have to do the section. No, I am not doing induction of labor. Just treat her as if she's single, all right? And then here, of course, induction by prostaglandin alone or amniotomy plus syntocinon is a safe in twin pregnancy and associated with higher rates of hyperstimulation and similar hyperstimulation in both groups. Cesarean section rates were similar, and the oxytocin, vaginal misoprostol, and Foley catheter actually were used for induction of with no difference in cesarean section rate. According to this study in 1999, there is a significant risk of unplanned cesarean section independent of the chosen method in induction due to nulliparity, late maternal age, no cephalic presentation, twin actually higher from the high country with perinatal mortality. I'll come to this in more detail with the French study, which is a really beautiful one. I'm going to talk about it in a little while. Here, actually, after the publication of the Canadian study in 2013, which found no clear difference, I just talk about between the induction of labor of twins and singleton or attended for cesarean, then came the French nationwide study, which is called the Jumuda study. Jumuda published in 2017, and they showed that higher actually neonatal mortality between 32 and 37 weeks gestation for planned cesarean than for vaginal delivery. So it's not really you are, doing her a favor. You are causing her harm actually by doing a cesarean rather than leaving her alone and do induction of labor. According to Jumuda study, 25% of twins were induced, which is 20% in the Canadian one. So French are doing much better than the Canadian. And term for twins is no longer 39 weeks. Remember, ladies and gentlemen, okay? But 37 weeks for dichorionic, 36 weeks of monochorionic. Remember this? This is a question in the exam, all right? Whenever you induce twins, depends on the chorionicity, all right? If she is dichorionic, you induce her at 37 weeks. If she is monochorionic, you induce her at 36 weeks of gestation. So now, I told you she is twin, and I told you when to induce her. So why you rush her for a cesarean section? Then, of course, we have the following, which is a comparison between in this French study, the twins versus singleton induction. All right. Here we can see that the antenatal variables, nicely stated, of course, as ART, IVF. Of course, most of the twins. 34% incidence in twins, 4% in the singleton. And this is another problem. We're going to talk about why we're doing lots of IVF, why we are putting 4 embryos for in ET or whatever. But however, there is higher incidence of preeclampsia in twins. We all know that. We have actually threatened preterm delivery also higher in twins group. But this is antenatal variables that is well known to all of us. Then we have, of course, the 37, 39 weeks, which is really something higher rate in the gestational age. For the intrapartum variables, you can see here the convenience on the comparison. Actually, there is 20% in the twins and only 7%. So it seems to be that induction of labor, actually, it has been more convenient to do it in the twins. Premature of membrane was 6 and 25% in the other one, because usually you can wait on the twins rather than on the singleton where they rush with the amniotomy. And here, of course, we have the Bishop score, 6 to 7. Started at twins, about 37%, and only 18% in the singleton, because, the twin pregnancy in itself, having that increased weight in the uterus, putting lots of pressure in the cervix, will help you during the labor induction, because it will dilate easier. And that's how we find more higher Bishop scores with the twins rather than with the singleton. And of course, you can see here the use of oxytocin actually is doubled in the twins than in the singleton group. Moreover, in this French study talking about the vaginal delivery is achieved in 77% of induced twins and 80% of induced singletons. Is there a difference, 77 and 80? So you're gonna reach or achieve vaginal deliveries with inducing twins just as if you are inducing the singleton. Why you section her? And of course, the main indication for cesarean section induction of or induced twins is failure to progress. Somehow, okay, not everything will go fine with you or whatever, but you have failure to progress, which is as a reason for induction of labor, you go for cesarean. Now, the factors associated with successful and unsuccessful induction of labor in twins, 62% had a vaginal delivery. Now, the two variables that is more related to the success here is multiparity. An odd ratio has about 12.3. Okay, to have more vaginal delivery. And also the maternal age. Look, less than 35, because usually when we say, oh, an old primate, and an older woman, so cesarean section, all right? No, but here anyway it's obvious that it has also an impact, which is the odd ratio only 2.3. And then maternal morbidity. Increased in women required cesarean section after induction of labor versus women delivered vaginally. 17.5 versus 1 per 6. Imagine. So every time you do a cesarean section for a woman, for whatever reason, even if it's that twins or non-twins, I mean, you're putting her at this risk, which is really blood loss, more than 1,500, uterine atony, we've seen it all, and also use of more than one uterogenic agents. So this is compared nicely between the two induced groups, and you can see the cesarean one, you're putting your patient at risk rather than really saving her life. My final word, ladies and gentlemen, labor is a natural process by which uterine contraction results in a cervical change and subsequent delivery of an infant, whether spontaneous or induced. The hope is that labor will result in vaginal delivery. And induction of labor is a viable therapeutic option for appropriately selected patients. However, the benefits of continuing pregnancy must be outweighed, of course, by the potential maternal fetal risk associated with the procedure. And thank you very much.
Dr. Hisham, for this great presentation. We're always learning from you, Dr. Hisham, and you pointed out a very, very, very important point about twin delivery. Nowadays, we are not really seeing a attempted vaginal delivery in a twin pregnancy, and I feel sorry for all of this new generation. For this. So part of it, I guess, lack of education from the patient, and also some of physicians really they tending to advise the patient for a cesarean section as a more safe in twin pregnancy, which we all disagree with this, based on all this evidence that we have seen today from Dr. Hisham and Dr. Badros. I think we invite all the speakers to come to the stage to answer the questions from the audience. And now the door is open for you for any question to the speaker.
Mike.
Any question to the speakers?
أحمد عندك سؤال أكيد هي.
Thank you very much for all the team. Just my question regarding for all of you, CTG monitoring. We know that it is very important nowadays in the medical legal issue. When you go to the investigation and you find some people talk about interrupted CTG and not to do continuous monitoring. And there is a missing part of the CTG. Maybe the investigator will stress, where is this segment? Maybe something there going on. So how you are going to evaluate? Especially, I mean, we don't add to the CTG, for example, fetal blood gas. We don't add the internal monitoring. Most of the unit is far away from this. I mean, previously, Dr. Hisham, he knows that when we are in the residency, we do the fetal blood gas monitoring, we do the internal, electrode monitoring. How you are going to defend about the doctor who deal with such a case if there is a problem or fetal problem?
I will ask Ms. Raghat to answer the first half, then I'm going to answer it from the fetal-maternal point of view.
Actually, when I heard about the medical legals as a midwife, I have a perspective and point of view. If we let the medical legal and the fear of the getting problems and getting نتحاكم بالميديكال legals of the CTG, it will not make us as a professional as we want to be. Because if these patients, in the first place, I'm talking about the low-risk patients with this my scope of service as a midwife. If these patients originally was low-risk patients and we do the intermittent CTG and yet we have the medical legal missing parts or not CTG or the CTG was intermittent, we did the best practice we can do. And in my point of view as a midwife, we have always to do the best practice, the evidence-based practice, regardless to medical legal, because medical legal will happen anyway. So I prefer to happen with medical legal, and I preserve my professionalism and I preserved my evidence-based practice rather than doing to avoid this medical legal and not be professional. So this is my point of view, but I'm sure Dr. Nadia have maybe a wider point of view.
Okay. I know where we come. I have been in this litigation for how many years, and I went to court so many times. We have two problems. The first problem that people who are coming to the committee, usually they are not fetal-maternal, they don't have fetal-maternal background, they don't know exactly how to read the CTG. CTG should be read whether this baby is hypoxic or not. And with a tool which is low sensitivity and specificity, I think few people can tell whether this baby is hypoxic or not. This is the first thing. The second thing, most of the cases have been reversed if we're going to UK for babies who had HIE. With the previous tools, they've proven that most of those babies, they have the HIE for a reason not related to labor. They are now using another tool where they are doing the MRI early. They don't do the CT scan because it's not sensitive. They are not doing the ultrasound because it gives a lot of pitfalls. So most of those obstetricians who have been incriminated, sorry to use this word, for negligence during labor and be a cause of HIE, they have been cleared. You can go to the literature and you can see all these names and all the new tools for the HIE in particular. So we need to use these tools to decrease the litigation, decrease the incrimination of obstetricians who come to the hospital. The only aim is to protect the lady and protect her child. So we need to go for the litigation to change it. And I think that now the changes that's coming, they are looking for something called eyewitness, where for each case, they bring the expert, where have been, especially those who are working. So he have been there, he have seen it, he know the latest update regarding diagnosis of HIE, for instance, which is the nightmare of everybody. I hope that I answered your question.
دكتورة نادية، أنا I will interfere. أنا عضو في الميديكال ليجل كوميتي.
Good for you.
فأنا will tell you the secret or كيف أنت to protect yourself in this situation. CTG زي ما قالت لنا أختنا رغدة it's not, don't depend only on the machine. It is, you are the one who is monitoring. There is a lot of CTG courses. Dr. C. Bravado, the كلكم you remember. طيب, how to protect yourself? By two things. By good documentation and communication. معظم الميديكو ليجال ايشوز دائما بتحصل بيوقع فيها الفيكتيم. Most of the time are the resident, some of the time are the specialist. To protect yourself, read a CTG. It is your judge. You are the one who is monitoring at that time, at that spot. So what you are seeing at that time, documented well, put your plan very clearly in each time in the CTG, and communicate with your senior and put the plan of the senior. Now you will be safe. What happened to the baby? Regardless, he is sick, he is well, even if they complain, back to your note. I read the CTG at that time, and this is my plan. Nobody will gonna blame you. As long as you are already certified, you are already a physician, you are already a obstetrician. The problem is most of the time, they are seeing CTG, they are not document, they are waiting, and we don't know what is the plan. And case after 2-3 years, he's forgetting what happened, and the problem comes. So it is only two things: documentation, communications, and that's it. And you are the one who is monitoring, not the CTG. Yeah.
I have a question from the audience on the Zoom. A question says, why sphincter injury in patient with VBAC is more than in prima gravida?
There was no an explanation. It have just a statistical. They look for all the complication and they notice that they are higher than in Nebaris, but they did not write exactly what's the explanation.
Okay. And this question for me: breech extraction for the second cephalic twin. Second, this is your experience in evidence-based. Well, of course, if the first twin is breech, then that's your excuse to do cesarean, okay? But if the first one is cephalic, this is really the time where we apply what we said, talk on induction of labor, etc., etc. But then, regardless of the second twin, whether it's, transverse, cephalic, or breech, or whatever. And any questions from here, Doctora?
My question for you, Dr. Hisham. All this approach and art for induction of labor that decrease rate of cesarean section for twins pregnancy. Can we apply all this for triplet or quadruplet twins for triplet? Yes.
Can
we can apply this one or never ever?
Not really. You cannot monitor the third baby. This is the dilemma.
Dilemma.